Assalamu alaikum. Welcome you everybody. This is our usual regular meeting of the Sharqiya Echo Club with our Echo members that you are waiting for us, I hope, every month. This time is a little bit different with more also people, I hope, and topics that you will really enjoy and get the value of it. We have here two speakers and two panelists and one speaker from our hospital for a case presentation. We will be starting by Mr. Ray Garcia. He is an eco-technologist, medical education from GE company. He will be presenting a talk about the contrast enhancement. And then Dr. Sami Ghazal, who's well known to us in Saudi Al-Babtain Cardiac Center, non-invasive cardiologist. And he is the medical director of Saudi Al-Babtain. He'll present the clinical application of the contrast. We have our panelists, Dr. Eric McWilliam and Dr. Ali Shahri from Johns Hopkins, non-invasive cardiologist and interventional cardiologist, both of them. And they will be part of our panel. Dr. Ayman, he's our senior registrar from King Fahd Military Hospital, who's gonna present at the end the case presentation. So we are most welcome, Mr. Ray. You can start please with us. Thank you.
Thank you. Thank you very much and welcome everybody. And I want to first of all thank the Saudi Heart Association for inviting me to give you this presentation on contrast echo. It's my honor. It's the first time I've ever presented to an international crowd. And so thank you so much for this opportunity. Let me share my screen here. There. Is that, can everybody see that?
Yeah.
Yes?
Yes.
Okay, great. So this talk is going to, include it's how to use the agents with your systems. Now, as we all know, it's very easy just to inject the agent and then just assume that the system is going to do everything. There are some minor changes and some physics that you have to be aware of. So this is just going to be very basic. There aren't a lot of things on your equipment to change to enhance the outcome. So to begin with, let's see. This is not forwarding. There we go. So as I said before, my disclosure is that I am an application specialist for GE Healthcare and the Pharmaceuticals Diagnostic Group. That's my background. I've been doing ultrasound for 40 some odd years, starting in the very beginning. And I've been doing contrast since it started on the market as well, using these ultrasound agents. Familiar with most of them and as well as most of the equipment also. So why use the ultrasound enhancing agents? I think what we have to be here in the United States, as you well know, we have the American Society of Echo. They state that if there are two segments, contiguous segments that you cannot see, two or more, then we should go ahead and use the ultrasound enhancing agents. Last year, or actually about 2 years ago, the ASC started this campaign to start changing the verbiage of using contrast, the word contrast, to an ultrasound enhancing agent. And so therefore, you'll see many times that we start saying contrast and sometimes ultrasound enhancing agent. And it's really hard after you've stayed in contrast for so many years to start saying ultrasound enhancing agent. So I'll do my best to try to go back and forth, but I may slip and say contrast. So besides the two or more contiguous segments, why do we use it? So we increase the accuracy of the volume and the ejection fraction in 2D, right? And then also that gives you, the audience, the physicians, and also the sonographers that are acquiring the image, some confidence as to how to interpret this, what they're seeing, what is the function, what is it, and when you go back and you measure your 2D images, you'll have a better assessment as to what the outcome is going to be for those measurements. So that's one of the reasons we use it. And besides that, we also have this accreditation committee here in the United States that essentially is saying the same thing. So for anything that has a poor endocardial definition, then we have the ability to use the ultrasound enhancing agents. That's essentially what the committees and the commission is saying. Now these numbers are very low in our interpretation, but they say that there's an estimated of 10 to 15% of the routine echoes completed out there that have incomplete endocardial resolution. You cannot see the endocardial border. Of those 10 to 15, there's probably 25 to 30% of those echoes that are usually performed in the ICU or other units that again have an incomplete endocardial resolution or border. You can't see. So the suboptimal echoes can be, when you use the agent, those suboptimal echoes can be converted to diagnostic images in about 75 to 90% of the patients. That's a big number when you think about it. So I know that Dr. Sammy is going to show some, and Dr. Amen will show some interesting cases and how you can see that conversion, but it helps so much in the resolution and the outcome of that patient and also the decision making as well. So, but to get there, you have to do some very basic things with your equipment. First of all, what kind of patients do you use contrast agents? Obese patients, patients with lung disease, those that are critically ill, and despite all that, all the tools that we have on the equipment, you still may obtain a suboptimal echo, but you have to make it diagnostic, right? So all these patients will need some sort of contrast agent to optimize their images. So whether it's obese patients, patients that are on chemo also have need some agents occasionally. Three things that will make your contrast pictures really beautiful. And these are three key components to optimizing contrast agents. First of all, the equipment settings. Equipment settings is important. Regardless of the age of the equipment, whether you just received it, it's brand new, 2020 GE, Philips, whatever you may have received, that's one. That will have a different setting than, say, if you have a piece of equipment that's maybe 10 years old or 5 years old. The software changes, the processors change. Equipment settings is a big deal as to optimizing and getting the best out of your equipment. Secondly, how you dose it. As you well know, we have 3 agents here in the United States, and some places only have 2, some only have 1. But each agent is different. They have different properties, and how you dose it is going to be very important as to the outcome in combination with the equipment settings. And then administration will make a big deal. And we'll talk about administration. I have some great examples as to what happens with the administration. In the equipment settings, there are 3 generally controls that you will change or play with on your piece of equipment. The first one will be your transmit power, or as it says here in the settings, mechanical index. These words, power and mechanical index, change back and forth. We typically say mechanical index, or we call it MI. MI, standing for mechanical index, may range from 0.1 to 0.3, depending on the age of the equipment. What's the benefit of that? It will prolong the visualization of that bubble destruction, persistence, as we call it. So it'll persist longer depending on that range of mechanical index. Secondly, the focus. Focus we will typically take and we'll put it in the far field. It will decrease swirling effect, but what does focus do? Remember, if you have a focus in the middle of the image, then that's where all your energy is going to meet. And then it will converge and then it'll diverge from there. So that is essentially the focus, the sweet spot. Works great for tissue, not so much for the enhancing agents or contrast. So focus, we take it and we put it in the very far field. You really don't need it. It'll work only in the apical areas if you choose to use it, not so much in the parasternal views. Dynamic range of compression just increases your visibility. It makes your image softer, more contrasty, or more bistable. So that is a personal decision, how do you like to see your images, whether they're soft or whether they're a little bit more bistable? It's up to you. So those the companies typically put them in the middle, and that seems to be well, unless you like it a little softer, a little more bistable, then feel free to play with those as you like. Gain. Now, the one thing about gain is that gain is very nice, especially in tissue. Not so nice when we use it in contrast agents. And why is that? Because if we use gain, what's the first thing we do when we can't see something? We turn up gain, right? Everybody does it. Now, all sonographers, anybody that's scanning will turn up their gain right away. The problem with that is that you increase all the noise levels of tissue as well as contrast. And then you have a very faded type of image. It's not very diagnostic. It's not very specific. That's why we use transmit power. The other one that's not listed on here is your TGCs, or your time gain compensation. And so as we say here are some of the things that you will change or play with in your system. First of all, when you activate the contrast software, it will automatically activate harmonics. In your software, there's 3 types of softwares that the manufacturers develop. We never know which one we're playing with. And in the I believe it's a 2014 ASC consensus statement, they list the companies that are using types of software. But there is nowhere on your system that you're going to find power amplitude modulation, or it won't say pulse inversion, or it won't say multi-pulse sequencing. So those things are just accepted as to what, when you activate your software, it will automatically come up. So harmonics is activated sometimes automatically. You can take it off, but typically when you activate the software, it comes right on. As we already mentioned, the focal zone is set to the micro level or below. I prefer it all the way down in the far field. At the micro level, you're still having that where it may shadow that specific area. You'll adjust your TGCs, and this is the first thing that you will adjust, will be your TGCs. So your TGC should be above the center or higher, because that's will adjust the energy. That's going to add more energy without adding more power. Okay, so it's going to give you more visualization. Mechanical index is your power. That can be adjusted anywhere from 0.08 to 0.4. Once again, that depends on the age of equipment, whether you're using a brand new system just developed, or you're using a system that's 10 years old, a legacy system. Ideally, when you activate the software, most systems, most manufacturers will have it at 0.3. So once again, as I said, system dependent on age and stuff. Adjust your overall gain as necessary. And what I mean by adjusting gain, first of all, TGC. Secondly, mechanical index. Thirdly, gain. You may use 1 or 2 notches of gain just to give it a little boost. Now, understand that dynamic range of compression just as necessary as you like it. Frame rates will be automatically adjusted with the software. So once you activate the software, your frame rates are about mid-range. Power, mechanical index will overactivate the bubbles and they won't last long. I have two sayings that says, if your image changes, if it gets brighter or if it gets dimmer, immediately look at your mechanical index, typically found in the top right-hand corner of the screen. Look at that mechanical index, and if it's anywhere above 0.8 or 0.4, if it's not where you started, then adjust it back to that area that you wanted. If it gets too dark, that means your power went down. That means it went down to about, let's say you started at 0.3. It probably went down to about 0.16. So bring it back up to where you started or adjust it as you start seeing that tissue visualization. So keep your eye on the MI if you notice that your image got too dim or too bright. Do not go to gain right away. That'll just not make the image very, very nice. Optimize your contrast for tissue. I mean, optimize for contrast, not for tissue. I said that. So optimize all your settings to optimize the contrast settings. And I'll show some pictures here in a minute, not for tissue. Some other best practices you can see. So when you have the proper contrast field of view complete with your in your left ventricle, it's opacified beautifully. It may be showing half of the left atrial. That's okay, because the function or the focus, I mean, is in the left ventricle. So make sure that you've activated your contrast package on your systems. If you don't have a contrast package, and many of you may not, there are ways to optimize your system by lowering the energy. And you would need some assistance in doing that from your application specialist in your area. Adjust the gains, as I indicated before, but adjust the gain, that would be your TGCs and your mechanical index. And then finally, and the final point, use the patient's breathing techniques, whether they inhale or exhale, have the patient breathe so that you get the best out of your image. And sometimes that helps. That's all you need to do to just optimize your image. So when you adjust, as I said, there's 3 components in here that you have to be careful with. And one is your equipment settings. The other one is your dosing and your administering. So when you eject, administration is very important. The key into administration is to inject very slowly. If not, you will get attenuation. And that's what this picture is showing here. This bright area, when you inject too fast, all the agent will gather here in the near field. And then it takes time, if not seconds, for it to opacify the entire left ventricle or the cardiac image. So right now, this is due to a fast injection, a bolus injection. And now we have to wait, it could be anywhere from 15 seconds to even sometimes 25 seconds, depending on the patient's heart rate, okay? So it's a well-known artifact, typically caused by 2 bolus of an injection. So to decrease the bolus, we inject slowly. It's a manual infusion. And that's what this graph is indicating here. This is what happens in a bolus. So you can see the time that it takes, it will last. It'll just stay concentrated and then it starts to disperse, not giving you a long time to gather your image. You end up with gathering a lot of artifact. But if you inject it slowly, manual infusion, then it'll persist longer. And that's exactly what we're looking for, is that nice, beautiful image. And that's what we have over here. The first image on the left is attenuation. And then we inject slowly, and the image on the right is a nice, persisted, opacified cardiac image. So you can see especially here in the posterior wall or the infralateral wall, as we say, is really nicely defined. Now understand that your mechanical index up here, you can see that is 0.18. This is a Philips system, and this is probably one of their newer systems, but 0.18 is really nice. Their frequency, this is on what they call a res. So these 3 things, on a Philips system, if you change the gen to pen, then it will change your mechanical index. It will do one of those too dark, too bright when you go from gen or to pen. So be careful when you change frequencies. And typically we like to start in the gen or even maybe something like penetration. So as I said at the beginning, what type of patients need contrast agents or these ultrasound enhancing agents? Obese patients, big patients. And that's when we'll use a different frequency. When you do that, keep your eye on the MI, look out for 0.8. If it gets too dim, then it's gone down. If it gets too bright, the mechanical index is gone up, okay? So this is a nice infuse. So when we say infuse, how slowly should we infuse it? Painfully slow, painfully slow. This is really fast. So this is not a medication. Remember, these contrast agents are not a medication. They're a tool for us to get a pretty picture. So use it as a tool and inject very slowly. We have a different mixture here in the United States as you may have out there. So we tend to use the entire vial with mixing it with about 7 cc's or 3 milliliters of saline. Sometimes we'll even take half of that vial and infuse it with 18 milliliters of saline, depending on the study that we're going to use. So depending on the study, whether it's stress, perfusion, or whatever, will depend on how we dilute that solution. So once again, to get a nice pretty picture here on the right side, you will administer it very slowly. So again, it's the time, persistence is the time, the contrast is filling the left ventricle. More persistent is commonly due to an insufficient amount of microsphere injected or the inadequate machine settings. In other words, the settings aren't correct. It's not persisting. It's probably your settings are off, or it's not staying its longest, you probably, the dilution mix could be on. It could be one of those three things, and it's very simple, whether it's your equipment settings, your dilution setup, or how you administer it. Those are the three things that are key, okay? The only time you will inject a little quicker, and this is the only time you inject a little quicker, is when you have a low ejection fraction. Because imagine if you have an ejection fraction 20 to 25%, and it's doing this. A low administration, it's not going to get from the right to the left side. So you might have to push it a little faster. So if you notice ejection fraction being a little low, be a little more aggressive with your administration. That's just one of the keys. If it does attenuate, and let me go back here a little bit. Let's say you do have this attenuation. How do you overcome it so it turns to the right side? One of the things you can do is take your machine and put it in on freeze. So you freeze, you deactivate the transducer. And that deactivation, you wait about 10, 15 seconds for it to now start persisting or opacifying the entire cardiac structure. Okay? So if you do end up with attenuation, hit your freeze button, deactivate the transducers. That way, the energy, the sound is not overactivated or sonicating the microsphere. Okay, so that's one of the things that you can do. So once again, how do we get attenuation? We inject it quickly, or we're not injecting enough product, right? So we have to administer more. That will cause lack of persistence, low cardiac output, as I said. Low ejection fraction, low cardiac output. You might have to inject just a little faster. That's the only time you'll do that. Another thing, that incorrect machine settings. Okay. Just a quick case study, and this is a 55-year-old male. I want to show you what a really nice picture looks like. So this 55-year-old male has a history of hypertension, type 2 diabetes, and heart failure, and they ordered the echo for a stroke. Now look at this. This is really pretty stuff, right? I don't think a lot of us would even think about using any of the agents to opacify this, right? The more you look at it, you can see he has a low ejection fraction. Something may be going on here, but why would you want to use on something like this, right? Especially down here. But if you see this little fuzziness down here, it could be hiding some stuff, right? You can see something that's right here. So when we inject, we decide to go ahead and inject some contrast. And all of a sudden, for this patient that who's having a stroke, there it is. Nothing in the parasternal, beautiful short axis. We have the 4th chamber here, but in this 2 chamber, look what's coming out there. Okay, you can see it a little bit on the 4th chamber of the previous image, something suspicious, but here it definitely comes out. So even in the prettiest of images, you want to consider something, especially if you're looking for strokes. Other areas you might want to use this is in the subcostal use. If you want to enhance your Doppler signals, if you're going to use the agents to enhance the Doppler signals or capture it after you've used it, you want to go back and do some Doppler. Do it as the product is almost out of the system. Do it at the end of your imaging study. When you do it in the middle of the study or you're doing it at the beginning, you'll have a lot of baseline noise. So try to do it at get all your Doppler waves at the end of the study. In color is okay, but not the best, but it really helps out in the spectral signals. If you're using it for transesophageal, make sure you inject very slowly, because otherwise a fast infusion is going to, again, attenuate, and then you have to sit there. We don't want to sit in down the patient's throat no more than we have to, right? So a slow injection is important, especially if you're doing Watchman procedures and you're looking for thrombus or clots in the left atrial appendage. Thank you so much for this. I hope I could help out in some of the techniques, and I'll pass it on to Dr. Sam.
Thanks a lot, Mr. Ray. It was really very nice talk. And I've personally, I've learned a lot from the way that you have presented things. At the last slide that you've told us about that case, can you put it again, please? The last slide with the echo?
Yes.
So you're saying that when you, can you just?
Yeah, I'll go back.
Right.
You want it
So,
with the contrast or without the contrast?
yes, with the contrast. So here you're saying that there is something suspicious in here on the,
So
right.
here, as we look at these two images, really this is in these apical areas. It was fuzzy here. You can see
Right.
that, and it's really not well defined. I would be suspicious as to something there. My eyes were attracted to that right away. But then I look at this little area right in here. And
Yes.
this is suspicious. I would
Yes.
probably use some other imaging technique, zoom,
Okay.
you know, and try to
Right.
increase that area to focus. And just to be sure, we will
Right.
break out the contrast agent and
Yeah.
just to be
In
sure.
this picture, yes, in this one. So in this one on the left side, which is down here, I don't know whether you're seeing, I don't think you're seeing,
Yes,
but
the
it's
apical point,
right,
yes.
left, right. I could see that there is an area of echo
Right in there?
hypotenuse areas not taking the uptake, right?
Right.
Here, the black one on the septal. This is supposed to be 4-chamber, right?
This is supposed to be a 4-chamber view, yes.
Right. This black near the epicoceptal, epicoceptal area. Is
Yes,
this a
right here.
suspicious for an LV thrombus just because we're not doing it a little bit lower down? So we're taking part of the epicardium or no? Because this one on the right side down, it looks very clear it is a thrombus-like or.
Correct. And I think when we use these agents, it certainly clarifies the endocardial border very nicely so we can see what's going on. But as we see the walls are very minimal in movement, then we start seeing like trabeculation or something that's make it very suspicious. And then, you know, you'll start doing some other techniques of scanning techniques to probably bring this area out and maybe even zoom or so. But certainly here in this apical long axis, it looks very nice. Or maybe that's even looks like more of an apical 4 that's just been adjusted just a little bit to bring it out.
Right. Okay. And what I'm just trying to say, I mean, sometimes when we don't have the upper part of the epicardium of the apex, part of it has been taken up. If we go a little bit down, we will have more clear picture to show us the endocardium and epicardium together with the whole apical segment. And sometimes this will show you more hidden pathology like a thrombus, which is laminated in that area. So
correct.
do you agree in this? Okay, very nice, very nice. Thanks a lot. Thank you. So thank you for being so punctual on time. I really like it. Okay, so now we are with Dr. Sami. Sami Ghazal. He's going to present at the clinical applications for the echo contrast. Please, Dr. Sami. Unless, لحظة شوي, Sami, please. Do you have any comments, any questions from the panelists? Okay, we can leave it later. Okay, Sami, please go ahead. Thanks.
I would like to thank Ray. He made my life easy and he set the floor for me to proceed for the practical use of contrast and echocardiography. So just to try to finish quickly, so we'll have a pleasant night. Since 2018, now we have a new term or nomenclature about the contrast. Now it has been called the ultrasound enhancing agent. And the reason for that is not to to confuse it with a contrast that has iodine material and which will cause harm to the kidney. So this is a different medium. To call it a contrast, still okay, but you know, for the patient, maybe calling it an ultrasound enhancing agent is better terminology. It's a microbubble. It has an outer shell that is filled with inert gas. Most of them, you know, depending on the brand, then you will have different gas and different outer shell material. It has to be smaller than the RBC because it has to bypass the lungs and go to the left side. Currently, the commercially available, we have 3 of them, FDA in the US approved, the Lumazone, Definity, and Optizone. And you can see this is a difference between the diameter here as well as the shell component. Is it phospholipid like an optizone? It's a human albumin and different type of inert gas. How to prepare? Also, it depends on the company. For example, optizone here, the way you prepare it, you just put it in your hand and you roll it between your palms until you have a resuspension. Definitely, for example, you have to use agitator, which is a specified machine to shake the vial vigorously. It can be given as a bolus and infusion in case of optizone and definitely. Lumazone is a powder formation and it will be mixed with saline and it's given only as a bolus. Action, it is less than 1 in 10,000. And the main adverse reaction we are worried about is hypersensitivity. We don't have any data for pregnant or children below the age of 5. Policy should be available in all the center using contrast about how to react if you have an adverse reaction. Now speaking again for the second time about mechanical index. So mechanical index is a quantified representation of the power. It is calculated by having the power here, or it is the peak, the negative peak pressure divided by the square root of the frequency. So imagine if we have more frequency, we will have less mechanical index, etc. So when you change the machine setting, you know what you're doing. Mechanical index is divided into very low mechanical index, low mechanical index, intermediate mechanical index, and high mechanical index. Very low mechanical index is below 0.2, low mechanical index is between 0.2 to 0.29, and intermediate 0.3 to 0.5, more than 0.5 is considered high mechanical index. Now, how the microbubble will react to the ultrasound. So it will oscillate. Oscillation means compression and distension. So it will compress and distend. This is the response to a low mechanical index pulse. And it will respond to in a non-linear fashion. So that's why it means it will not reflect the same frequency. It will reflect a harmonic frequency. So if you try to image in the fundamental frequency, you will get nothing. You will get zero because the bubble will always react in non-linear reflection to low mechanical index. If we give a high mechanical index, the bubble will burst and we will not have the effect we are after. So again, quick talk about the settings. Now, if we have the software, it is well and good. In case we don't have a software, we have to use the low mechanical index or at least intermediate mechanical index, but we have to use it intermittent for imaging. So we take the image and we stop. Frequency should be lower to improve attenuation. So the ultrasound wave, because it is a low power, in order to have it travel further into the tissue, maybe the patient is obese, which is most likely, we need to have frequency a little bit lower. The main aim of contrast or ultrasound enhancing agent is to cancel everything and only see the contrast. So we need to filter the tissue, we need to filter the artifact, and we keep only the contrast. So we have to put the filter or rejection should be increased maybe to the maximum. So we need to filter everything else other than the contrast. Compression is when talking about how many shades you have. Maybe if you have it lowered, you can see black and white or without a gray. So it will give you a better visualization. And again, of course, should be adjusted for a reasonable visualization of the contrast. Again, always use harmonic. If you don't use the harmonic, just forget about it. You will never see anything. Speaking about very low mechanical index. Very low mechanical index, it's a software. You need to have this algorithm and this package. It will produce a better image quality. It has a multi-pulse cancellation sequence. So the machine will cancel anything other than the contrast. I will show you how it's being done in a minute. So pulse cancellation sequence, we have two techniques. Either it's a pulse inversion or amplitude modulation. So we have two different types. You need to know your machine what type of it will use. Like I know for GE, it will use amplitude modulation. I will tell you how it's being done. So in phase inversion or pulse inversion, the machine will send a pulse A, and then it will send afterward another pulse with opposite polarity, exactly opposite. The up is down and the down is up. And then we'll add them together. If you have a fundamental linear response, so the reflected wave is exactly the same as the sent wave, you will add them together, it will become zero and you will see nothing. As mentioned, contrast will respond in a non-linear fashion. So when you add them together, you will get something. You will have cancellation of the fundamental frequency coming from the tissue, but the frequency coming from the contrast, which is a non-linear response, you will be able to see it. Now, this is very smart and even a better algorithm. They decided, okay, we will send a pulse, and then we will send half of the power of that original pulse. And then we multiply it by 2 and we subtract them from each other. Why? I will tell you why. Now, the contrast will respond non-linear to A. However, because B is very weak, it's half of the very low mechanical index. So it will respond linearly to that. In normal tissue, you have linear response to both. You double this and you subtract them and you get 0, you see nothing coming from the tissue. But in contrast, you will have a linear response to this one, the very low mechanical index, even half of it, and non-linear response. And then when you subtract them from each other, you will get some waves. The benefit of this, or the main advantage, is you are imaging in fundamental frequency here and harmonic frequency. We know that harmonic frequency is double the fundamental frequency. So the lower the frequency, the fundamental frequency, the better is the penetration. So we have a better penetration with this amplitude modulation. Application. The main FDA approved application is LV opacification. Under that, you can see regional wall motion, you can see volume and ejection fraction, intracardiac thrombi, apical abnormalities, and non-compaction. It's all under LVO or LV opacification. The recommendation is when 2 or more LV segments cannot be visualized adequately, we have to use contrast. So ideally, it should be used every day. The LV volume, however, remember that the LV volume, you cannot compare the LV volume reference values of a contrast to a non-contrast. Usually the LV volume here is larger when using contrast because it will go inside the trabeculation. However, ejection fraction will not differ because the volume in systole and diastole will both be altered. So the ejection fraction ultimately will not be affected. I will go quickly showing you a case. What do you see? Next image, again, so we see nothing. Really, I cannot see nothing. I can report this case in 1 minute because everything is not well visualized. So contrast here, if you need an answer, is really mandatory. So when we give contrast, now we can see something, we can see the walls, we can see the contrast, we can see the LV function. This is 2-chamber. I want to show you that we are putting number 2 here, or we are writing 2-chamber. It's a good trick to tell which chamber is which. Because sometimes the interpreter, he cannot really tell. Another example, this is another case. Really, we cannot really identify the walls and wall motion in a good manner. This is when giving contrast. Of course, it depends on the operator if you like to use amber or temper color, or you keep it black and white. Usually that color is better. Again, we are writing the chamber here, so we know what we are dealing with. I'll show you another example. I'll go quickly. Okay, this is another example. Now, you have a bad LV, so now you already have a substrate. You also have the ICD. So you have a substrate for a thrombus, and maybe there is a thrombus here. But in order really to tell the size of the thrombus, the shape of the thrombus, and is it mobile or not, maybe we have to use contrast. We will think this might be a mural thrombus. This is when giving a contrast. You can see this is the focus here, because we are really interested in the apex. And you will have some attenuation down here because we are injecting a little bit fast in order, because the LV is dysfunctional. As Ray said, in order to get all the contrast to the apex, maybe we have to inject it fast. So this is a mural thrombus. Thrombus will appear as a filling defect. It will take no contrast. Another case, looks normal. Some wall motion abnormality, I can tell. RV is fine, the apex is not. We are concerned about maybe a thrombus here because the apex is not fine. Is it a mural thrombus? Maybe. Now we gave a contrast. Again, if you note, we are writing the chamber here, so we know what chamber is that. Now you can see easily the thrombus, the shape. Now this is not a mural thrombus. This is a large pedunculated thrombus attached to the apex. So now we see it very clearly and we can measure it. Let's show you another example. Do you know what is the diagnosis here? If anybody from the panelists would help me and tell me what is the diagnosis or what they see, what they think is the diagnosis, I'll give you 5 seconds. Otherwise, I will go ahead and tell you.
Non-compaction.
Very smart, very smart, very smart. Okay, so exactly. So this is a non-compaction. Look at the area here. Look at all that trabeculation. Remember the echocardiographic criteria of non-compaction. So we could not see it really in without contrast. So with the help of contrast, we can see a lot of trabeculation. Even short axis, look at short axis. Look at all that trabeculation. Now you can do all your measurement, compacted area versus non-compacted area. So this is a case of non-compaction shown beautifully in contrast. Contrast can be used in for LVE classification, even in stress, because it's part of stress. So not doing a stress because we have a bad image is no longer an excuse. We can now do a stress echocardiography even if the image is not good, as long as we have a contrast in hand. Okay. Another from the panelists, anybody help me and tell me what is the diagnosis?
Typical hypertrophy.
It's radical Hawking, yeah.
Good, good. Are you confident?
Yeah, and it's out to 10.9.
Good. So
100%.
let's make it 100%. Is it 100% now? So this
Not the
is
typical slit lamp.
exactly. So this is the typical presentation of apical hypertrophy. See that spade, because we play cards, we know what is the spade sign.
Run it, Sammy, because we didn't see the second one is spade shape. Let it run a little bit. Manish.
Okay.
Yeah, this one. Yeah.
Sure.
The next one.
So this is
This is very nice.
yeah, this is a 2-chamber. And this is the spade. Another case. What is the diagnosis? You got 2 right now. I need the third one right.
Symmetrical hypertrophy, but
Exactly. So this guy came to the clinic. His complaint is really not very specific. Some shortness of breath, maybe chest pain. But look at this septum. Really, this septum is huge compared to the small posterior wall here. I would call it immediately asymmetrical septal hypertrophy and maybe start with HCM and from there. However, I looked at the ECG. This is his ECG. You don't expect really this ECG in those type of patients. And then speaking echocardiographically, if you have a very good relaxation velocity, you really have to reconsider your diagnosis one more time. Really, I don't think this guy is having the criteria for hypertrophy. So we injected contrast and let's see what happened. So this is his contrast, and actually his septum is normal. And the thing that we saw is maybe part of the RV here, or probably a papillary muscle of tricuspid valve. So he doesn't have hypertrophic cardiomyopathy. Now, all of this is related to LV opacification. That is the labeled use of contrast. We have now off-label use of contrast. We have myocardial perfusion stress echo. We can use it in pseudoaneurysm, and we see that contrast will leave the LV going to the pericardium and left atrial appendage, intracardiac mass, and Doppler signal enhancement is also an offline use. For example, the right-sided Doppler enhancement, we can use it like an aortic valve. Usually, if we use agitated saline for the right side, but for the left side, if you really want something, you can use the contrast. I'll show you another example. Okay, so what is the diagnosis here? That is a very easy one.
can you run it?
It's not running.
Oh, it is now. It is.
Rheumatic valvular heart.
Rheumatic. Very good, Ayman.
Okay, good. So that is rheumatic mitral valve and even rheumatic aortic valve. And the reason we are doing TEE, probably we want to balloon this valve. And we know the contraindication of balloon. So that is the appendage. I'm not sure, shall we balloon or shall we maybe put some anticoagulation and see later?
Looks a sludge.
Yeah, actually sludge should be really treated like
Yes, if
normal.
it is heavy. Yeah.
But since we have the luxury of contrast, you can see really we don't have a filling defect. This is zero filling defect.
Very
We have
nice.
all the contrast going all the way to the tip of the apex. So this is another off-label use. I'll speak also about myocardial perfusion stress echocardiography. This is an off-label use. I will just brief you and orient you about that. It is usually a visual assessment. It's either normal versus abnormal segment. You compare the normal segment contrast uptake versus the abnormal segment. It has to be continuous infusion of contrast. You need to have a software ready. You cannot use it if you don't have a software ready with a function called Flash. So Flash is a brief, maybe 5 to 15 frames of high mechanical index. The reason of Flash is used to destroy all the micro bubbles. You don't need any bubbles, and then you start counting the replenishment rate of the myocardium. You assess replenishment at end of systolic frame. Now, during rest, normal is between 4 to 5 cycles, cardiac cycle, you will have a full replenishment of the myocardium, of the muscle. It will take the contrast. During stress, the normal is 2 cycles. So if replenish after 2 cycles, it is delayed. So how we do it? We start infusion. Then we do Flash, and then we do assessment for the resting images. Then we do stress, and we do Flash. Again, we destroy all the bubbles, and then after the second cycle, we do all the assessment. So how we describe? We describe either normal, when the tissue, the abnormal, all the tissues are the same. We compare tissue to tissue. So normal is normal during rest and stress. Fixed defect, you have it during stress, and it should be rest and stress. Reversible is during stress only, and it's not there during rest. So this is the interpretation. It's very easy, but you need the function of the Flash. So this is how you do it. So after, let's say, 4 cycles or 5 cycles, you compare the abnormal to normal tissue. Like, look at this apex here. It did not really take any contrast compared to this. It's a visual comparison. It is very easy. And so now we have a fixed defect during stress and rest. About intracardiac masses. So we compare also enhancement to the myocardium. So if there is no enhancement, it is likely a thrombus. If there is incomplete enhancement, so lower than the myocardium, it really will take some contrast, but it is not as the myocardium. Maybe a classical example is myxoma, incomplete enhancement. Now, complete enhancement, it will be exactly like the myocardium or even more. We call it hyper enhancement, and really suggestive of malignant mass. Ray already mentioned this. I just repeat. Maybe your contrast is too much or too little. We need to see how to overcome. So now you have attenuation or shadowing here. So the contrast is too much. We have to wait and then see what happens. Simply just wait. Either you keep, freeze your machine, or you just keep watching to destroy some micro bubbles. So that is too much micro bubbles. Sometimes too much micro bubbles is really needed, because you really need, in a dysfunctional LV, you need to push the bubbles to go all the way to the apex. So really sometimes it is needed, and you can take 2 separate images, one for the middle part and one for the apex, where you push really high contrast. So we have LV filling and destruction rate. So if you have destruction rate is high, either you reduce it or you increase the LV filling by giving more contrast. And this is too little contrast. It will give us an effect which is called the swirling effect. You will see like it will, the blood will swirl in the LV. At least here you can see something, but really sometimes all the swirling will be down here and you see nothing up here. This is another example of too much contrast, attenuation, and shadowing. You just wait. And one last word, don't forget about the RV. You know, I know it's LV opacification, but once you inject, immediately you will see the RV. So have a look at the RV and really assess the RV function with the contrast. Thank you very much.
Thank you, Sami. It was really very excellent, comprehensive talk. We need a few things in here. I think it's open for questions before we present the case by Ayman. We have here, regarding the contrast, you said, first of all, you can ask you or Ray, anyone can answer me. In renal impairment, they say when it is severe renal impairment, do not use contrast. So they say in severe heart failure, severe lung, severe kidney, everything is severe, do not use it. But what do they mean by severe? In this stage, people who are in dialysis, can we use it? Patients with intermediate clearance of above 30, can we use it? Any experience? Because this was not clear to us in the data.
So from my point, maybe Ray can help me in that, but I really don't know about that statement. I think you can use it in this stage renal disease. It is, you know, it will be exhaled in, with a breath. Even heart failure, I think this is an indication. I don't think that is valid anymore. Ray, any thoughts?
Yeah, I've heard this question before, and sometimes I believe what happens is that they get confused with contrast that we use in the invasive areas versus the enhancing agents for ultrasound. So they interpret it to mean the same thing. So it's simply just to tell them and say that where there is no contraindication for medications, I think all the agents that are available in the market today don't have a contraindication to medications. That means that whatever the patient is receiving through IV is generally can be accepted to go ahead and proceed with an ultrasound enhancing agent, because again, it is a non-ionic gas that we're using, and so therefore it would be pretty safe. In patients in dialysis, the problem with dialysis is that it filters, so it never really gets to the heart because it's the microspheres get destroyed in the filtering process. So that becomes a real, unless it's after dialysis, and we all know that after dialysis is probably the best time that we can get those beautiful pictures on patients. But during dialysis process, I wouldn't attempt to use it. I don't think it would.
Okay, but in fact, Ray and Sami, this is written in the pamphlet of the SonoView and Optison, that it is in severe cases of end-stage severe lung, severe heart, severe shunt, severe renal impairment. It's written there in the pamphlet. I agree with you that it's not the same as the ionic, but in the ultrasound enhancing agents, that's what's written. And I fully agree. I've never had any problem with any one of them. I did it in acute MI when it was even contraindicated at that time. But just I wanted to make it very clear. So you think it is safe at any time, even in dialysis, not I mean during dialysis. I mean, in cases who are in end stage with dialysis, we can use it. That's great. The second thing, Sami, regarding the enhancement, myocardial enhancement. Well, I don't think it's as easy as you are describing. Yani very nicely here, beautifully until you mention it. But when we do it regular, have you noticed when we're doing the contrast, just LVO, simple LVO, you could see that there is enhancement of the myocardium nicely and the septal and lateral wall, for example, inferior and the basal proximal 2/3. And you don't see an enhancement on the apical segment, even though it's a normal. I cannot explain why sometimes it takes enhancement and sometimes does not. So I did it in cases where I did MCE. And honestly speaking, does not show as it is easy. Yani. It's really sometimes difficult to pick it up and say, yeah, it is not perfusing the apex and it's not perfusing the lateral wall, unless it's a clear MI. You know what I mean? But
Yeah.
I don't know, what's your experience? Please let me know.
No, actually, because it's an off-label use, and now contrast is not cheap. Really, we keep it for the very solid indication. We don't use it. Maybe we use it 1 or 2 times only just for fun. But if we have nuclear available and other stuff, we prefer to spare the contrast where it is truly needed.
Okay. Dr. Eric, Dr. Shehri, are you using it in, what do you think of using the, you're using contrast a lot, right?
Well, I think we've had the same problem, with getting supplies of contrast. We had it for a while and then we lost it. And I think I share with Sami, it's procurement of the contrast, but we haven't used it for actual perfusion. We've just used it for LVO classification. But I think it's something that we should look into. Because if you look at the data, it's really very impressive to increase the sensitivity of stress echo. It really, in fact, supersedes nuclear imaging. If you look at the data, people who do it a lot, like Roxy Senior and people like that, the data is very, very impressive for mice, for myocardial contrast echo. So I think it's something we should look at.
Yeah. Okay, Dr. Ali?
Yeah, well, I agree. I actually looked at few images and few cases of myocardial perfusion, and I still find it difficult for myself to interpret it and to really have a quick guess on the perfusion images. But I think you're right. I mean, it is something that is coming, and maybe we should start using it until we get good idea about it. I think it's coming.
Okay, somebody's asking.
By the way, sorry,
Yes.
there is newer software that will do some automated contrast and all that graphs, etc. So this is the simple way to do it, but if you have maybe a dedicated software, it can be done in an easier way.
No, we have icons, specific icons, by the way, Sami, in Philips. You have it where you have to click it and do MCE, the myocardial enhancement contrast, and you just click it and it will do the flash and everything. It just, the one which you are saying, it's something which is more of objective assessment, that it tells you the flow in that area or segment, and it would compare it to the others. And this will be much better but this is, as you said, still under research. Somebody's asking, how can you differentiate between myxoma and malignant? Sami, with the contrast, can you?
So with the contrast, so all the other criteria, we know the criteria of myxoma and how the appearance. But in contrast, we said myxoma will take a little bit of contrast. It will not be as compared to the myocardium, so it will be partially enhanced. While malignancy, if it is really enhanced or hyper enhanced, it is malignant. Doesn't mean if it doesn't enhance, it's not malignant. So I mean, if it enhances, it is likely to be a malignant. Myxoma will take some uptake.
Right. Okay. I think you did. There is a question: technique difference between LVO and myocardial contrast. I think you've explained this regarding the LVO. Just the difference is the flash. One more thing regarding the MCE, by the way. Also, we've been using it, that you can do first the rest with injection, not infusion. طبعا the best, as you said, infusion, because it will maintain the picture and the flow of the contrast all through the exam. But you could do it at 2 steps. You could do it at rest and then you could inject again and do the flash at the stress, which is later on, and will give you really beautiful if you don't have the infusion, because it's a bit sometimes difficult to do the infusion. Mr. Ray, somebody's saying, can you share our slides, your slides with us? Because it's really very informative and they would like to have it as a share. Is that fine with you?
I'd be happy to share them. I'll send them to Osama or to Mohammed.
Sure. Now we are with Dr. Any questions from the panel?
Yeah. I have a question. I mean, certainly all the black box warning that were taken out from the side effects, except for hypersensitivity for the material itself, but the rest of the contraindications are all taken out. My question is about people who have a documented large shunt, like a large ASD proven before. Do you really need to do the contrast? And if you do, is there a true risk behind that or not?
So I'm aware that this was taken out before. It is a contraindication if you suspect, shunt, but it was taken out, and I don't see a problem of doing, because the contrast itself, it will go to the left side anyways. But Ray, if you have any thought about that.
No, this question has come up several times for us here in the United States, that depending on the size of the shunt, but as you said, Dr. Sami, it's going to the left, it's going to the right side, it's going everywhere. So we haven't seen any adverse events or reactions from that, and they have used them in large size shunts. It was removed 3 years ago from everybody. So all the manufacturers can now use agents in patients with shunts. Pulmonary hypertension was removed about 8-9 years ago. So that no longer is an issue. The only contraindication we have is to not use it in ladies that are pregnant or nursing and children here in the United States.
Yeah. By the way, do you still get a consent for the
Yes.
For the injection? I mean, is it a mandatory thing? We still get a consent, but is this really needed?
To us here, it's dependent on your institution, but in general, we don't get consents.
We don't. Where we do it, we have a credit lab, and we don't take it. We have a policy, and consent is not part of the policy.
Excellent.
I mean, if you're doing a contrast, you're giving a dye which is something exogenous, and it might have some sort of hypersensitivity. It's like you're giving a medication, so you should have at least the general consent for it. For example, when you're giving a patient any antibiotics, you sign the patient consenter for admission and giving all the medications. But as an outpatient, how can you give her a medication, or even it's a contrast, doesn't matter, something which may cause hypersensitivity without taking consent? This is a bit strange.
That is debatable, but people in the US, they are not doing that. It's good.
US?
Yeah, because Ray is from the US, and he said they are not doing that.
Ray, but you don't get a general consent for the patients when you're getting them for your when they are seen by physicians. I think you have something called general consent.
The general consent is typically for inpatients. Once they, when they are admitted, then they will sign a general consent. And so therefore, there is no need to consent them again as an inpatient. As an outpatient, every lab is different here in the United States. They're not all consistent. And what I have found, there's a small percentage of labs that are getting consents, but in general, the larger population, they're not getting consents for whatever reason.
Interesting to know. Yes.
Because I think, I mean, consent, I mean, makes it cumbersome. You need to have somebody, a physician, to come by. You delay the procedures. It's really a lengthy, I mean, we face it every day because we don't have a physician available at the same time. The other point, I think we should really empower the techs to be able to decide when they need to use it and go ahead and use it. They don't have to wait for a physician to come by and recheck with them, because they are experienced people and they are the ones who can judge, I mean, at the time. So I think we should really try to push them forward to make a decision and just use it.
Absolutely.
Absolutely,
I fully
Dr. Ali.
agree.
We have standing orders here in the United States that state just that. They, as the sonographers, as they see fit needed when following the ASC consensus and standards, then if they need it, then they will go right ahead and use it. But
Okay.
standing orders. is what we use.
Somebody's
Yes, yes.
asking how left heart valvular disease may affect the quality of LVO. I don't know. Sami?
I mean, if you have, severe, maybe mitral regurgitation, similarly to in the cath lab when you inject them. So yeah, it might not, reach the apex. So it will affect. Maybe you have to inject more, a little bit more, but definitely there will be an effect of mitral regurgitation, particularly.
Yeah, I'm going to tell you at least the severity of MR.
Yeah.
Somebody's asking, well, how can we diagnose ARVDS by the RV dysplasia? Have you come across something like this in the RV with the contrast? I think we could do it with the right heart bubble study. Also, it could show it nicely if you have. But what do you think, you, Ray?
If you minimize the image, the four chamber, you will see the inflow of contrast, and then you can always go back and freeze that frame and have the ability to quantitate the RV in systole or diastole. But you have to minimize that four chamber. The software will automatically increase the image of the left ventricle. So you just have to physically reduce that, go to 16 or 14 cms, whatever it takes to make that smaller. And then you can look at the inflow.
Okay. So I think we can start now, just make a nice end with Dr. Ayman. He's presenting a case. I hope it will be interesting. And we need the cooperation and the comments of the panelists and the speakers, please. Ayman, please.
Thanks, Dr. Qaddura. Thanks for the organizing committee to letting me a part of this valuable meeting. So this is a case presentation. Our patient is named Mr. Jassim. He's 67 years old gentleman. He's known case of diabetes, hypertension, smoker. In 2016, he experienced an anterior STEMI and received thrombolysis in south. And the coronary angiography then showed multi-vessel disease for medical treatment. And he had also an LV thrombus, and warfarin was started. Cardiac MRI at that time showed non-viable distal LAD territory. He presented to our hospital in October 2019. His complaint was 1 week history of cough, chest pain. He sought medical advice in south. There was troponin leakage, and he was labeled as non-STEMI with this chest discomfort. He signed DAMA and came to our hospital. His ECG showed old anterior STEMI, and let's review his serial echoes together. This is his echo in 2016. This is the parasternal long axis.
Ayman. Ayman?
These distal apical segments are a little bit more dyskinetic. We can see here obliteration of the LV apex with the thrombus. And also notice here the level of the LV apex in relation to the RV apex. And this is a zoomed view. We can see here the central vacuolations and this apical LV thrombus. This is his echo upon presentation. It's the parasternal long axis, and this is the short axis. We can see that the basal segments and the mid segments are contracting well. We can see here some bright echogenic anterior wall with some dyskinesia. Oops, and this is his apical four chamber.
Can you hold on, please, Ayman?
Sure.
Can we have comments, please? panel?
Well, it seems that he has developed a large pseudoaneurysm of the apex. His
Okay.
apex is kinetic, scarred, and probably he has developed. You can see a very thin septal there, which is part of the apical wall, and there is a big pouch just above the RV, which I think is a pseudoaneurysm.
Okay, excellent. Continue, Ayman, please.
Sorry, is somebody talking?
Ayman? So until Ayman join again, I don't know what happened with his. So what would you do next? This is a patient who came after he has sustained an MI 3 years back, and now we came and we saw this defect. We put a color Doppler there, and it was there was a shunt, as you clearly indicated.
Call the surgeon.
Call the surgeon.
It would be an excellent case for a contrast, actually.
Hello, yeah.
Did you use contrast in this case?
Likely they did.
Okay, احنا will just call the surgeons, huh?
Yeah, of course.
Will you be happy? Do we have surgeons between the audience? If there is anyone, please, can you shout? Or raise your hand. Are they happy, you think, the surgeons to take the patient without more clarification?
Yeah, I think they'd want more imaging, you know.
Yes.
And as my colleagues were saying, I think contrast would be a good initial step.
Contrast. We are not in a topic of contrast, Dr. Eric. We need. It was suggested by our colleagues to have an MRI or CT to be more delineated. What do you think? What would you do as a surgeon if he asked you this?
I think if you will have a beautiful images with the ultrasound enhancing agents, to tell you the truth. I'm not sure how much MRI will.
Okay.
With the Definity or the others.
Yeah. In fact, by the way, I heard that you're not having now enough contrast. He joined us, just Ayman. He lost the contact of the internet, so he's just rejoining. Regarding the contrast, Definity, we used to have Sonoview. Isn't it you were having in John Hopkins Sonoview or Optison?
No, we used to have Definity, and now we're having Optison.
Optison. And it is available now, right? It is available. I mean, we can have it. Just we're having difficulty in purchasing it. But also there was also Sonoview, and it is really very easy to use and very friendly and get you very nice images. In general, the cases that you're using contrast with, most of the time, is it because of wall motion abnormality or to delineate thrombus? My colleagues.
Dr. Abdura, I'm back.
You're back? Okay. احنا وصلنا عند أيمن الإيكو of 2019.
Yes, sorry for this technical issue. We reached here in the echo upon his presentation to our hospital in October 2019, and we reached specifically this image. This is the apical pole chamber.
Yes.
We can notice here something going wrong in this area.
Okay.
Okay. So these are some zoomed views. Okay. This is the color Doppler. We can notice here that there is some flow from the LV in this side. This
is it through a septum? What do you think? Is it going to the septum or free wall or where?
Actually, this is a possibility to be.
No, and I'm asking el panel, yeah.
I think it's going through the free wall.
Free wall.
The apex.
I think apex, the free wall, part of the distal apex, and the free wall around it.
So it's not including the interventricular septum, right?
No, it will be otherwise a VSD.
Yeah.
Right.
Yeah, for sure. It's not a VSD. You have the typical back and forth, to and fro flow. through a shelf-like defect.
Okay.
Yeah, I bet my money on pseudoaneurysm.
Pseudoaneurysm. What else would it be if it's not pseudoaneurysm?
Nothing.
طيب
Maybe.
you bet your money on what?
Yeah, so some people they might say maybe aneurysm.
لا هي البوينت is exactly Sami, and I think we need to delineate this a little bit more because people were asking in one of the questions, and I left it till now, how can you differentiate between pseudoaneurysm and aneurysm? So please, can you highlight this on this image? It's your
yes, you can. Yeah.
Go ahead, Sami.
Yeah. So you have the shelf-like defect. So usually you have a narrow neck and then wide base of the defect, and then you will have to and fro. So the flow will go to and come back from the defect. And if you can see the defect, sometimes it will bulge. It will be pulsatile. So all that you can differentiate. And also, if you track the wall, the LV wall and all that muscle layer, you will not see it in the defect because it will be covered by pericardium only, not part of the muscle.
Okay, so it will be loss of the intima itself. There is no myocardium, and there is only the pericardium outside. And you will have a neck, small neck, and a large cavity. Ya Rabbi Ayman, you are back. I don't know if we lost you again or what. This patient كانت الquestion before طبعا if we have it as a VSD, so you will see some flow going into the RV, and we cannot see anything. But from the start, if you remember, we showed you that the apex of the interventricular septum, the apical segment, is going too low from the large area of the apical dyskinesia, which was initially covered by the thrombus. And this was nicely seen. Ayman, please.
Okay, yes. So this is also the apical two chamber, but it's a little bit foreshortened. And this is the apical long axis. Okay. So our question, this is the debate or the dilemma, is this LV aneurysm, pseudoaneurysm, or this is VSR? And where is this? The second question is where this? Do you think that it's in the true apex, in the apical septum, in the apical inferior? And the third question, what would you do next if we have surgeons here, or you are the primary cardiologists of this case? What would you do next? CT, MRI, TE, maybe other imaging modality?
Okay, I think they have answered the Ayman. Our colleagues have answered before that this is typical of pseudoaneurysm, and it's coming from the apical area. It's not involving the septum. Okay. And I don't know why they have suggested contrast. No one have suggested CT or MRI, by the way. No one. I don't know. I have no idea why. But go ahead, yeah, Ayman. Let's go with the contrast.
I think the surgeon will not agree to take him based on the contrast.
Exactly.
You're obligated to do something. You need to do something more, but he will be very happy.
I have to disagree. I have to, the surgeon maybe would ask for a coronary angiography and to see if they will do CABG or not. But
yes, I agree with you, Dr. Sami, and we did already coronary angiography, and we will present it. But for the sake of confirmation of the diagnosis and accurate delineation of the size of the defect and its extension, we elected to do contrast echo, as we see in these images. And we can see here the neck of the pseudoaneurysm, and it's filling a huge defect confined to the pericardium. We can see here the accurate extension of and the maximum diameter of this huge pseudoaneurysm, and we can compare the sizing of the neck to the maximum diameter. These are additional images to the contrast showing to and fro flow from the pseudoaneurysm. This is the apical two chamber showing intact inferior wall and intact anterior wall. This is the apical three chamber, showed also that the infralateral wall is intact and the anteroseptal wall is intact. We went for coronary angiography, and it showed focal lesion and the LCX and mid-total LED occlusion. These are some caudal views for, and this is, sorry, the LAO cranial showing the mid LED total occlusion. And we can here see the RAO cranial showing mid-total LED occlusion. And this is the spider view. And actually, the consensus was not doing any intervention for the coronaries because the right coronary was imaged before and it was small non-dominant. So all the money is in the LED and the LED is non-viable. So to minimize the duration of the intervention, they elected to do nothing for the coronaries. And this is the surgery. They removed this pseudoaneurysm and did repair for the ventricular wall with, as we see here, this is a patch suturing and closing the defect in the LV apex. We also elected to do contrast echo after the surgery to make sure that the defect is completely closed and no residual shunt. We can see here nicely that despite being dyskinetic, but it's intact. And this is the apical two-chamber view, and this is the apical long axis. So LV pseudoaneurysm, this is a free wall rupture of the LV and hemopericardium, which is confined into the pericardium. It accounts for 3% of the acute myocardial infarction. It can also occur in the post-cardiac surgery, blunt trauma, or as a complication of endocarditis. Consequences, it increases significantly the risk of sudden cardiac death. There is risk of also of thromboembolism and congestive heart failure. The most common involved artery is the left circumflex and consequently the infraposterior wall. The echo findings shows narrow perforation as we saw with sharp edges in the left ventricular free wall. There is might appear systolic expansion in the pseudoaneurysm with extension of the aneurysmal space behind the LV ventricular wall, unlike the true aneurysm. We may see also some displacement of the surrounding cardiac chambers. We have narrow neck diameter to true diameter ratio less than 0.5. If we are lucky enough to align the pulsed wave Doppler, we can see two peaks and to and fro pulsed wave Doppler, and also the color Doppler shows turbulent flow and abnormal flow within the pseudoaneurysm. We have also to decrease the color velocity scale in order to better visualize. Regarding the management, surgery is considered till the moment is the cornerstone, but it might be some challenging, especially if it's in the acute phase, because suturing in the necrotic myocardium may fall apart and it has a high surgical mortality. But leaving it alone with the medical therapy alone carries higher mortality. Transcatheter repair is an emerging solution. It can be done under fluoroscopic guidance, as well as also 3D TE or transthoracic imaging, like placing a Platzer device or doing some coiling to obliterate the pseudoaneurysm, or combination between both. Okay, so take-home messages. LV pseudoaneurysm is a diagnostic dilemma. Contrast echo, despite being an off-label use, but it provides great help regarding the confirmation of the diagnosis, precise location, and follow-up after the treatment. When facing a difficult situation in your Echolab, use all the tools in the box and always remember contrast. Thank you.
Thanks a lot, Ayman.
Thank you.
Thank you for your case. By the way, I want to tell you that the surgeon wouldn't have, as Dr. Ali have said rightly, he wouldn't have been happy at all. When I told him I'll do the contrast, he said, contrast? I said, yes, contrast. No. We'll do it. He said, MRI. I said, no. Fortunately, it was my patient, I think. So I said, no, I'll do contrast. When he saw the pictures, he was really impressed with it a lot. And he felt that he's seeing a CT scan in front of him. And he took him to surgery with all confidence. And when he saw it exactly the same way that we presented. So I know that contrast is not yet seen a lot with people, and they don't know it, by the way, despite it has been present for years and years. but still it is underused. It is underused in many aspects. In our Ecolabs, by our eco-technicians, by us in different modalities. And I have patients who had LV mass, and there was question whether it is malignant or it is benign mass, and it was in the left ventricle, and it was a large one. We did a 3D, TE, and everything we did. We did nuclear, they did cath, they did MRI and CT, and they all got the idea that it is malignant because there was a flush, there was enhancement, but in fact, with our contrast, it did not have much enhancement. And even with our 3D, it was showing that it is more of a benign mass and there is no invasion. And truly, when it was taken to the surgery, it was a rhabdomyoma. So I think our utilities in echo is really excellent. And I think we should use it more and more and more frequent. And the hope by time, the use of the LVO, mass, etc., and the MCE, and still have lots of hope in the MCE. In fact, I wanted to do a paper 5 years back, but because of the lack of the contrast, we did not. Thank you a lot, everybody. Really, it was very nice talks. It was really great help. Somebody from the audience was asking one last question, unless the panels they have. I know maybe Ray, you have answered this. You said there is no contraindication for ultrasound enhancement agent. So people, everybody, if anything there, you quote Ray. He said no contraindication at all. And Sammy concurred with him. So if you have anything, you go to those two.
I will say
Except what? Non-hypersensitivity to the contrast agent itself, or maybe because albumin, to use a human albumin, patient cannot receive a human albumin for any reason. He cannot receive optizone because optizone has human albumin.
Okay, those are very rare things, Malish. If you have, anyhow, I'm telling everybody, it's Ray and Sammy. And somebody said occlusive, vaso-occlusive pulmonary hypertension. Vaso-occlusive, it means pulmonary embolism. No, huh? You shake your hand. No. Ray?
Not anymore, not anymore.
Not anymore.
Yeah.
No single contraindication except hypersensitivity. It's very clear.
Yeah.
And no consent.
Pregnancy and nursing.
And pregnancy.
Yeah.
Pregnancy and children below 5.
Yes, has not been studied. Yeah.
Okay, great.
Great. And I think there's even people now are talking about using the ultrasound enhancing agent as a potential therapeutic option in the future, because those particles are purely intravascular and they never leave the intravascular structure. And then if you go to the muscles, the myocardium, there is a potential that if you put a growth factor into those small particles, or if you inject any kind of proteins or genes or something, this could be a therapeutic option in the future. And I think there are some research going along this side. So I think we should just familiarize ourselves with it, use it more, get better with it, because the future, I think, is going to be very bright in this part.
Dr. Ali, there's a really great committee, or I should say organization called, I don't know if you all are familiar with it, but it's called ICUS, ICUS, International Contrast Ultrasound Society. And the International Contrast Ultrasound Society has a lot of the work that's being performed today, whether it's therapeutic or diagnostic, from the heart to the vessels to kidneys and so on and so forth. If anybody is interested, they should log on to icus-society.org. And it's free to join. It's global, and there you'll find a lot of great research being done there. And a lot of these questions can be asked as well, such you're asking today. So great researchers, physicians, just about anybody that's interested in microspheres and the development and progress, you can go to ICUS Society.
Excellent.
I would definitely recommend that.
Beautiful. Thank you.
Great.
And just to mention that the ASC, the American Society of Echo, has a very nice presentation on contrast echo as well, learning presentation that you can get CME as well, but it goes over all the basics to quite advanced. So it's very a good resource as well.
Okay, and it is there is in the guidelines. It has been, I think it has been set last year, 2019, I think, about the contrast, right? They have published one in SE.
18.
Okay, all right, great. Any other comments before we end our presentations? I think there is, just let me look if there is any comment. There is experimental use for recanalization of LKD thrombus, LV thrombus with use of high mechanical index. Oh yeah, LAD thrombus, I think he meant. Somebody was using in experiments. Yeah, I'd like to have, it's a nice question. For recanalization of LAD, they have been using this high mechanical index, which is the flash, to destroy the bubbles. They have used it to destroy the thrombus within the left atrial descending. Any comments, Ray or Sami?
I don't have any experience with that. No, I'm sorry.
Yeah.
I think a wire and
in
a
fact,
LID will do it quicker.
Now?
I think a wire and a balloon in the LID will do it quicker. So
No. Soon we're not going to use this. Don't worry, Dr. Ali. We will not need interventionists.
Interventional radiologists have performed, using the catheter for pulmonary embolus, and that uses ultrasound energy to enhance thrombolysis. So you need lower dose lytic agent. So that's something that is being done, and we're doing it at the moment. There's quite a lot of experiments about, enhancing thrombolysis, but I'm not familiar with it.
Yeah, interesting. Okay, dear. I think we can conclude, and I really thank every single person here. We thank Ray, we thank Sami and Ayman. I really thank our panelists, and we thank the organizing committee, which is Saudi Heart. We thank GE for sponsoring us in this meeting, and wish you all the best, everybody. Thank you. Ma salama.